Morning, everyone. Hi, my name is Laura Jacobs. I want to thank you, as I turn off my phone, I want to thank you for joining us and being part of Brain Injury Alliance of New Jersey's annual seminar. Before we get started, I'd like to remind everyone to enter your full name in the chat. This is our virtual sign-in sheet. So if you're going to request CEUs, remember that you must attend the workshop in its entirety. Complete the workshop evaluation, and if required by your discipline, complete a post-test. I will be entering that link in the chat for your convenience also. Zoom will provide a report of how long each person has stayed within the workshop. CEUs cannot be given if attendance is not verified. So this is very important to do. So right now, if you haven't already done it, please go into the chat and put your name in. Questions are encouraged. Please enter questions also in the chat, and they will be addressed at the end of the presentation. This workshop is titled Identification and Management of Dysautonomia After Mild Traumatic Brain Injury. Our presenters are Lauren Ziax and Jenna Tucker. Dr. Lauren Ziax earned a bachelor's in athletic training and a doctorate in physical therapy with a concentration in business from Northeastern University. Since 2015, Dr. Ziax has built a specialized comprehensive concussion management program, which she now leads at Park City Hospital. Her primary focus is vision and vestibular rehabilitation to address chronic headaches, difficulty with schoolwork, reading deficits, attention deficits, exercise intolerance, and dizziness and balance issues post-head trauma. Dr. Jenna Tucker is a clinical assistant professor in the School of Physical Therapy at Kean University, where she serves as the neurological content coordinator. She earned her Doctor of Physical Therapy with a minor in psychology from Northeastern University. She is a certified brain injury specialist and board certified clinical specialist in neurologic physical therapy. Her clinical experience includes inpatient, outpatient, and home care rehabilitation for adults with neurologic dysfunction, specializing in brain injury recovery. So with no further ado, Dr. Ziax and Dr. Tucker.
Hi, thank you so much for having us. We're really excited to be here today. We'll be talking about dysautonomia and mild traumatic brain injury. I don't really have any full disclosures other than I own an educational free website, and that's about it.
Okay, thank you for having us this morning. The only disclosure I have is that I am a voluntary member of the Brain Injury Alliance of New Jersey's Education Committee, who is hosting this conference today. Quick thumbs up, can everyone hear me okay? Okay, great. So at the end of our presentation today, our goal is for all of our participants to be able to identify and describe the symptoms that someone with dysautonomia might present with, to understand the basic general concepts of how dysautonomia is managed clinically, and to be able to identify patients who may be appropriate for referral to complete a Buffalo concussion treadmill test and further evaluation for potential dysautonomia diagnosis. So a quick review about mild traumatic brain injury. One of the challenges in the literature is that you'll often see the terms concussion and mild traumatic brain injury, and there's sometimes some confusion as to which one is describing what type of injury. While concussion is used primarily in sports injuries and mild TBI tends to be used more in the medical field, they are synonymous. So what they are referring to is some kind of injury that is caused by a traumatic force to the head and subsequently the brain. And this can either be a direct contact injury where the head comes in contact with a blunt object, or a rapid acceleration or deceleration or rotational force of the head that results in movement of the brain within the skull and potentially causing damage in that manner. One of the biggest challenges for those who have incurred a mild traumatic brain injury is that the symptoms can vary greatly and they can fall into a variety of categories. So there can be physical symptoms such as gait disturbances, nausea and vomiting, headaches. There can be cognitive changes such as difficulty with memory, changes in attention. There can be behavioral and emotional changes, one of the most common being very intense mood swings that can result. Visual and vestibular changes can result in quite a bit of dizziness and difficulty with balance. There can be sleep-related changes and a variety of other symptoms. Way back when, the original kind of old school mentality when treating somebody who had a mild TBI is they would be put in this kind of dark room. They would be told not to do anything until their symptoms resolved. And current research has shown that that is not the way to manage it most appropriately. And while it's out of the scope of this practice, it should be known that those who are managed appropriately and follow the current protocols, most of these individuals will recover in about 1 to 3 weeks on average, if they follow these protocols appropriately, as I said. About 10 to 15% of people that have had a mild TBI will fall into that category of a protracted recovery, where their symptoms may last weeks, months, even years. And that can be something that has to be managed a little more in detail, most commonly used using an interdisciplinary approach to really manage it. So as I said, one of the biggest challenges for somebody who's had a mild TBI is that their symptoms can fall into a variety of different categories. And so that often presents a challenge for us as clinicians. We can be very overwhelmed when patients present with symptoms that seem to be kind of all over the place. So back in 2013, Michael Collins and his colleagues produced a paper where they talked about these clinical trajectories for concussion. And essentially these trajectories are kind of buckets that we can lump symptoms into. And this really can help direct and guide the development of treatment plans for clinicians. So this trajectories that he included were vestibular, ocular, motor, cognitive, post-traumatic migraine, cervical, and anxiety and mood, which is very helpful, as I said, when we're starting to devise our treatment plan. But over the years, while treating individuals with mild traumatic brain injury, Dr. Ziaks and I discovered, as I'm sure many other clinicians have, but it's been a conversation between the two of us for a while, that there's another bucket that seems to have some symptoms that people can fall into. And that is autonomic dysfunction. Right? And our conversations over the years about this are with a catalyst for today's presentation, and to talk about these additional symptoms that can result after a mild traumatic brain injury. So we know that after mild TBI, there often aren't any visible signs and symptoms in regards to things found on tests or on scans, such as an MRI or CT. But what we do know are there quite a few changes that happen within our brain and our central nervous system. There's metabolic dysfunction that results, there's electrophysiological changes, there's a difficulty of the brain to regulate neurotransmitter release appropriately. And there are a lot of microstructural changes that occur. And as a result of these things, there's a change to cerebral perfusion. And what that can result in is difficulty for the autonomic nervous system to regulate itself properly. So we're going to talk a little bit about that. I know Dr. Fins in his talk this morning briefly mentioned the autonomic nervous system a couple times, and we thought it would be a little helpful to just do a quick review. So essentially, as many of you already know, the main goal and role of the autonomic nervous system is to support what we call the subconscious fine-tuning or regulation of all our organ systems, to maintain the ability to adapt to changes either in our external environment, so such as a change in temperature or light exposure, or our own internal changes, such as while we're feeding or a sexual encounter or changes in our postural control. And the autonomic nervous system also plays quite a big role in stabilizing our cardiovascular system. So you'll see here heart rate, blood pressure are all regulated by our autonomic nervous system. It also plays a big role in digestion. As you can see here, it regulates thirst and hunger. Sleep, which as many of us can probably attest to, if we don't get good sleep, our mood will surely be connected to that. And in our immune system function, which I'm going to mention in just a moment in more detail. So our two divisions of our autonomic nervous system, we'll talk first about our sympathetic division. And that's where often you'll hear the term fight or flight. And that's due to the fact that our sympathetic division is really it's really at its peak when we are either in a time of stress or a time of exercise. And its role is to increase our heart rate, increases our blood pressure, helps regulate bronchodilation. It changes our vascular dilation in order to accommodate that state of being either in stress or in exercise. And then in contrast, we have our parasympathetic nervous system, and that's referred to often as our rest and digest division. And its role really is to conserve our energy and to help regulate our body during this time of rest and digest. And in contrast to our sympathetic division, its role is to decrease our heart rate, decreases blood pressure. It increases blood flow to our digestive organs, again, for that digest component. And our parasympathetic nervous system, as some of you may recall, is primarily regulated by our 10th cranial nerve, so our vagus nerve. And one of the things I want to point out is that the vagus nerve is a major constituent of our immune response. So it plays a very large role in regulating our body when either there's been a pathogen invasion, so some kind of infection, or some kind of tissue injury and a direct impact. So as you can imagine, if our autonomic nervous system, particularly here our parasympathetic division, is not regulating properly, it can have quite an effect when we are trying to recover from a mild traumatic brain injury and that damage that's done to our tissue. So what exactly is dysautonomia, this phrase that we've presented to you? And essentially what it is an inability of our autonomic nervous system to properly regulate itself. There is a wonderful organization called Dysautonomia International, a nonprofit organization that we're going to talk about momentarily, that has presented these 15 subtypes of dysautonomia. There are some papers and people out there that may tell you there are more subtypes or less, but for today's purposes, we'll use that 15 number. And this dysautonomia can really be associated with a variety of different things. It can result from deconditioning associated with an orthopedic injury. It's connected to depression and anxiety. It can be found in individuals with neurological diseases such as Parkinson's or MS. It has a very, very high correlation with Ehlers-Danlos syndrome, and as well as we're going to talk about today, concussion and TBI. I do want to note here, although our presentation is focused on concussion and mild traumatic brain injury, you can absolutely see dysautonomia with any level of severity of TBI, so mild, moderate, or severe. Today, we're just going to focus a little bit more on the mild TBI population. It's estimated that there are about 70 million people worldwide that have dysautonomia, and it seems to have no discrimination for age, race, gender. It can really affect just about anyone. But due to the very large knowledge gaps right now and the ongoing research where things are really coming to light, it's estimated that that number is probably quite a bit higher. Okay, so as I mentioned, Dysautonomia International is this wonderful agency that's looking to promote advocacy and really supports quite a bit of research on dysautonomia. And right now they're currently conducting a very large survey for individuals with POTS. And POTS, postural orthostatic tachycardia syndrome, is one of those 15 subtypes of dysautonomia. I'm going to talk about that more in the next slide. But what I want to mention here is that there's this study going across about 15 countries. And what they're finding is that those individuals who have dysautonomia, it can take between 4 to 5 years for them to actually be properly diagnosed. And many of them have seen between 7 and 10 physicians right? And as you can imagine, this is quite a big cost to the system, cost to the individual, and can really affect their quality of life. It can be very frustrating for them to have to be constantly going through these tests and trying to figure out what's going on. So it's very important that Dr. Zeitz and I feel it's very important that we spread this awareness, which will hopefully help contribute to these individuals being diagnosed and managed appropriately sooner. I do want to note in regards to the quality of life, while some individuals with dysautonomia have some mild symptoms and it may not be too severe, those who do have a severe subtype of dysautonomia that are very largely affected, there are physicians who have quite a bit of experience working with these individuals who have claimed that the functional impairments seen in individuals with severe POTS in particular can be compared to individuals with chronic obstructive pulmonary disorder and or congestive heart failure. So those who are having really severe symptoms can be very devastatingly affected by these symptoms. Okay, so this is kind of the big piece we want to spend a little time focusing on. And as you're going to see, as I run through these signs and symptoms, a lot of them can seem kind of vague. They can overlap with concussion symptoms in general. So it can be very difficult to kind of tease out and determine based just on symptoms if somebody has dysautonomia. But what we want to promote is any individual who is working with somebody who they're suspected dysautonomia should pay attention to these subtle comments that they make, because there are certain key phrases that they may present that kind of send off a trigger in our mind to say, maybe we want to refer them to get a little bit more in-depth testing for this. So a common sign that you're going to see is dizziness or feeling of lightheadedness or visual changes during a positional change. So that would be going from sitting to standing, or from laying down to sitting up, or with prolonged standing. So standing for long periods of time, they can start to feel these symptoms. They can have heart rate irregularities. And some of you may sit there and think, I don't necessarily check vitals. That's not part of my scope of practice. But what you can listen for are these comments of things like, I feel my heart pounding. I feel my heart skipping in my chest. That can indicate some potential issues in the proper regulation of someone's heart rate. They often will present with an intolerance to exercise. So after they complete a bout of exercise, they may say, I feel totally drained, as in like I go for, a 30-minute moderately brisk walk and I come back and I am out of commission for hours, right? They have difficulty cooling down after exercise. So as we know, that autonomic nervous system that we talked about, the sympathetic division is going to be in full force while we're in a bout of exercise. But as soon as we finish that exercise, our body is supposed to transition to being regulated by our parasympathetic division, right? And we transition to that rest phase. And if our autonomic nervous system is not regulating properly, that transition is not done fluidly. And so it can be very difficult for these individuals as they're coming out of exercise. So not only is the intolerance maybe during exercise, where it's very difficult for them, but they may have a very difficult time transitioning out of a state of exercise. They may present with breathing difficulties. This is most commonly during exercise or stress, but it can really be at any time. They can have difficulty regulating their temperature, where all of a sudden they're very, very particularly sensitive to cold, or they overheat very easily since their mild traumatic brain injury. They tend to become very red or hot, flushed in the face, either during exercise or with stress. That's another common one. They may have sleep issues. Often you'll hear that they may have had a full night's sleep, but it wasn't a restorative sleep. They don't wake up feeling refreshed, right? That parasympathetic nervous system is not properly regulating their sleep. So they can feel very fatigued. This can be connected with mood swings. They can have quite a bit of anxiety as a result of this fatigue. That can also be associated with migraines. Another big one is GI dysfunction. So about a third, about 33% or so of individuals with dysautonomia will complain of GI motility that's too fast. So they may have some diarrhea or nausea and vomiting. And about 33%, another third, will tell you they have slower GI motility. So they can have cramping or constipation. And these types of symptoms can be connected with either weight loss or weight gain that can't be explained by an intentional change in life habits. Okay, so what I want to also talk about a little bit is that dysautonomia as an umbrella term. So I loved this image that I found. There's only a handful of those subtypes listed here in the image. Remember, there are up to about 15 that we know of. The two that we're going to pull out and talk about a bit today are, if you can see my cursor here, are POTS, which I mentioned a little bit earlier, and orthostatic intolerance. Those are the two that Lauren and I can attest to as physical therapists that we really play a role in regulating more often and are more commonly associated with dysautonomia after mild TBI. So you'll see here, remember, under that first umbrella, POTS and OI were two separate categories. But what we have to kind of clear up is that OI is an umbrella term in and of itself. And what it refers to are those symptoms that you feel when you either transition a positional change, so sit to stand, or for prolonged standing, where you can have a wide variety of these subjective symptoms. You can have dizziness, you can have nausea, fatigue, vomiting, changes in vision, right? So if someone presents with these symptoms, we would determine that they have an orthostatic intolerance or difficulty being upright, essentially. And so they would undergo some testing. And the most common test that's used to differentiate the type of orthostatic intolerance is called a tilt table test. And again, this is also outside the scope of this presentation to go into detail with that. But essentially, this individual's vitals will be monitored while they transition from a supine position to an upright position. And as those vitals are monitored, if there is a significant drop in blood pressure, so it has to be a minimum of 20 millimeters of mercury in systolic blood pressure and or 10 millimeters of mercury in diastolic blood pressure, within 2 to 5 minutes of going upright, they would be determined to have an orthostatic hypotension, right? That drop in blood pressure. So they would fall into this OH subcategory, okay? If they transition to upright, they have these symptoms, there is no drop in blood pressure to that threshold, maybe a small drop, but not to that threshold of 20 over 10 millimeters of mercury. They would, but they do present with an increase of heart rate of at least 30 beats per minute. They would fall into this postural orthostatic tachycardia, that high heart rate syndrome, okay? If you have that drop in blood pressure and you have orthostatic hypotension, you cannot be diagnosed with POTS. And so it's going to be one or the other. NCS, neurocardiogenic syncope, we're not going to speak about today, but just know that that is another one of the subtypes that may be determined as the diagnosis. So in general, the other thing to keep in mind when differentiating is POTS often has comorbidities, particularly Ehlers-Danlos syndrome is very common with it, Hashimoto's disease, and celiac disease. So if somebody who's had a mild TBI has a history of one of these other diagnoses, they are more likely going to fall into that POTS category. But again, they have to meet that criteria. If somebody transitions to that upright position during the test, they don't have that 20 over 10 millimeter mercury drop in blood pressure, and they don't have that increase of at least 30 beats per minute to indicate that it's POTS, but these symptoms have been going on for about 3 to 6 months, a long period of time, they would go back under that general umbrella term for just a general OI diagnosis. Okay. Something to keep in mind that the treatment of all of these diagnoses are similar, which Dr. Zayaks will speak on a little bit later. But of them, OH is a little bit more, tends to be more severe. So how does this all tie back to mild traumatic brain injury? So the AAN has stated that a concussion or mild TBI, that's why we talked about the terms being interchangeable, can cause anomalies of the autonomic nervous system. So we know that there can either be direct damage, so those microstructural changes to our central nervous system, to the structures that control our autonomic nervous system, and that can work to create that dysregulation. It can also be a result of changes in cerebral blood flow that can cause the ANS to have that inability to regulate itself properly. So back in 2018, John Pertab and his colleagues they did an analysis looking at 36 studies, right, that were looking at connections between the autonomic nervous system and mild TBI. And 33 of those 36 studies did find a correlation. So there's more and more research coming out in the last few years that's saying, yes, there is some kind of disruption to the autonomic nervous system after a concussion or mild TBI. And we believe that that's playing a role in the exacerbation of symptoms, particularly in those people that fall into that protracted recovery phase that we talked about, that 10 to 15% of individuals who have those symptoms longer than the typical 1 to 3 weeks.
Thank you so much. Okay, so that was a great overview of dysautonomia. And now what are we going to do next? So if you have a patient that you suspect is struggling with one of these subtypes of dysautonomia, you can provide patient education, and we're going to talk about that in just a little bit. If it's appropriate for your, if it's appropriate for your practice, then you could do some screening of the patient. And that might be that you just ask them some questions and you help them find a local dysautonomia or autonomic disorders program. They'll go under a variety of names. It might be embedded in a neurology clinic or a cardiovascular clinic. So across the country, it will look different depending on where you are. You can complete the screening in the clinic if it's applicable for your practice. So as a PT, I can do some screening tools. And then we can support the patient no matter what your practice type is in the journey. So whether you're a caregiver, the patient, a speech language pathologist, a psychologist, you can always support the patient no matter what. It's a quite debilitating disease sometimes, and so they're going to need a lot of help. In the world of mild traumatic brain injury, how we are screening or measuring for dysautonomia is that we're using the Buffalo Concussion Treadmill Test. And this came out of Buffalo, New York. That's what the name comes from. It's with Dr. Letty's group. And so this test evolved in our practice because it's the one used to look for exercise intolerance after a concussion. But now we're seeing the research moving towards exercise intolerance and dysautonomia being quite interchangeable. So it's the gold standard for exercise intolerance. The research is growing and morphing, and it's probably going to continue to change now that people are more aware of this dysautonomia link. There is a modified cycling protocol. However, I always stress to our clinicians and my colleagues that we try not to use the cycling protocol unless absolutely necessary. The whole point of the test is for the patient to fail the test and then to be able to give them an exercise prescription. So if they're struggling with exercise, it's really not in their best interest to modify the test to make them more successful. And also you have to do a lot of math. So if people can walk on the treadmill, I recommend that you do the treadmill test. Our goal is for every patient to receive one. It doesn't always happen, but that is our clinic goal. And it can help us look for those physiological deficits. So what's really cool about dysautonomia is the most accessible way to test for it is not swallowing a pill to test your GI system, which is one of the great tests, or taking small vessel biopsies of your arm, which is another type of test. But it's actually to walk on a treadmill with a heart rate monitor and see how your body physiologically responds. And that's quite accessible to everyone. So there are published reasons to stop the test, which goes under that concussion bucket. And then there's this weird evolving world when we start to talk about dysautonomia. The most important thing is that you want to know the max stage someone can achieve. So the test goes progressively more challenging, and there's stages within the protocol. And you want to mark the max heart rate that they could achieve. and you take 80% of the max heart rate achieved. So if I'm exercising and I get to a max heart rate of 120 beats per minute, I would take 80% of that. Math isn't my strongest suit, but that's somewhere around 100, 105 beats per minute, right? And the reasons to stop the test would be that the symptoms might increase overall more than a 3 out of 10. So if you start with a headache and dizziness, you get 3 total points across the board. If you get an onset of new symptoms, although we tend to be a little more generous because the dysautonomia population has all kinds of symptoms, and so sometimes we give them a little bit longer. If they reach a max effort, right, we're not falling off the treadmill in the clinic. So when we reach a max effort, we stop the test, and then a rapid progression of symptoms, which will often happen. What's been really interesting is we've had to create a lot of adaptations in our clinic, and perhaps our population is really skewed because we specialize in people who have a longer recovery. But what we were starting to notice above and beyond Dr. Letty's research is that if their heart rate starts to plateau, so what will happen is as you're exercising, all of us, no matter what your background is, know that as we exercise, our heart rate should continue to go up. And what will happen for these people is their heart rate will actually stop responding. So their symptoms will be elevating and their heart rate is sort of a flat line, maybe a very small curvature up. You could argue that could happen in a really high level athlete, but if someone is telling me they haven't exercised in 3 months, that's probably not going to be a normal heart rate response. We might get spikes and variability of heart rate, which is different than heart rate variability. So you'll see these really big waves in the same stage of effort, and that's abnormal. Their heart rate might start to drop. They might get symptoms that improve during the test and then a rapid onset of symptoms afterwards. So I've had patients tell me, I don't have that. I can exercise just fine. So where are all your symptoms coming from, right? And then we go on the treadmill test and they're doing great. And then they burst into tears because they have a huge autonomic response at the end of the test. So they're in the cool down stage and just have a mental breakdown, right? And so they might get these really rapid onset of symptoms afterwards. And then we're also tracking autonomic symptoms as well now. So not just concussion or mild traumatic brain injury, but abnormal sweating. We'll look for changes in peripheral blood flow. Maybe their hands are splotchy or cold. They might get irritability or anxiety symptoms, things of that nature. So we're in a constant state of flux because we're only about 18 months into this program here. So these are our current things that we're working on, and I'm sure next year it will look a little bit different. But currently we recommend, along with the concussion guidelines, that every patient starts after 72 hours with 20 minutes of light cardiovascular exercise, which should be a 2 to 3 out of 10 effort. So the analogy we would use is like you're walking an old dog. We don't want symptoms to increase more than a 2 to 3 out of 10. So that's what every patient gets on their initial eval. And then we have little buckets that everybody falls into. So we have ortho team members, and they would be the ones primarily to complete the Buffalo concussion treadmill test on their first or second visit. And we try to repeat it frequently, but it does take a fair amount of time. So often we only get to it every 2, maybe even 4 weeks, depending on how slow the patient is progressing. If they aren't seeing ortho, that means they're only seeing me. And then I have to make choices based on what the patient needs the most. And so I often only get to complete a BCTT if they're having symptoms consistent with dysautonomia. But as Dr. Tucker pointed out, those people are kind of screaming at you coming off the elevator. So you really know who those people are over time, and you know who you need to make that test a priority for. So there's non-pharmacological treatment interventions, which are the number one, other than some of the more rare subtypes of dysautonomia that we aren't talking about today. But for everybody who lives under the OI umbrella, the non-pharmacological interventions are the primary source of treatment, which is really exciting. It means that you don't have to be on a pharma drug for the rest of your life. All you have to do are follow some pretty basic instructions, and that will start to retrain your nervous system to work properly. They tend to be, especially on the POTS spectrum. But what we're noticing with our concussion patients or our mild traumatic TBI patients is that they tend to respond really well to the POTS type instructions. So technically these come from the world of POTS, but we've been applying them to all of our patients with mild traumatic brain injury because we get that extra boost in the first 2 weeks. And I love that. I love anything that makes you artificially feel better until the treatment works. So they don't do well with heat, cooling vests, spray bottles. I went hiking in the Vegas desert this weekend, and I had my little fan and my spray bottle ready to go for my POTS to try to last a little longer in 95-degree weather. TED stockings, which you won't ever get a patient to wear, but that is technically the best. But we recommend brands that come off of Amazon that are between 20 and 30 millimeters of mercury. Minimizing these exacerbating factors. So staying out of hot tubs. We're heading into summer. That won't be as big of a problem as it was in the winter mountains. Alcohol will be a trigger, carbohydrate-rich meals. That's because we have to shunt our blood flow to our core, to our GI system when we eat a carb-heavy meal. So if you avoid those big, heavy meals, these patients will do better. And then, of course, prolonged standing. If medications are required, or if you're really struggling to get a patient to comply with the non-pharma interventions, then you would start with a fludrocortisone, which is just a little nasal spray. It helps with volume loading, okay? Propranolol is a beta blocker. It has to be a very low dose. They've done some really great research on what types of dosages to use for propranolol, and there's a critical tipping point where it'll actually make their orthostatic symptoms worse. Mitidrin and the long one at the end there that I can never say correctly. But that one you have to be careful because it can increase some of the GI upset that patients are already having at baseline. So what we would recommend to patients as a PT is going to look different than what the physician is going to recommend. But these are pretty safe across all of our disciplines. So OT, PT, speech. We can recommend electrolyte replacements, 1 to 2 drip drop or liquid IV or comparable electrolyte supplement. These are only averaging about 300 milligrams of sodium, which is great for the dysautonomia in general population. For POTS, they might get recommended between 3 and 15 grams of sodium. Now, you try to eat 15 grams of sodium a day, I challenge you. It is very difficult. So that is a big ask. But what's great is ramen noodles has about 1,200 milligrams of sodium in them. So there's some pretty accessible ways to get high salt. You want to add a lot of volume. That helps us have more currency to work with in our blood system and our nervous system. Compression, technically for POTS, it's full length compression, but we have a really hard time with compliance. So we tend to recommend a Spanx type compression short or some knee-high socks, and then avoiding the triggers. And the best part is daily exercise is the #1 treatment. So everything else is supportive, and then the daily exercise will get us there. So patients are exercising at that target heart rate that they receive from the treadmill test, so 80% of the max achieved on the test for 20 minutes a day. And depending on where that patient lives on the spectrum of dysautonomia, that exercise might look very different. So it could be supine biking. You literally lay on your back and you pedal your feet in the air, or you slide your feet up and down on the wall. It might be rowing, which is a great horizontal plane exercise or seated exercise that gets your whole body working. Stationary bike, walking, it's going to be a lot lower than the patient expects, no matter how healthy that patient is. So our average prescription is starting around 100 to 110, and that has included some pretty high level athletes as well. So the nervous system is the great equalizer in all people. As they tolerate exercise better, we start to increase by about 10 beats per minute increments. If they're more chronically deconditioned, we might go a little bit slower than that, but the average patient is going to be able to go up by about 10 beats per minute, and our functional symptoms should be improving. So the patient should come in and say, I can exercise at 90 beats per minute, but now the bike turns on. So I'm not just pedaling so slow that I'm not generating any energy, right? So their workload in that heart rate is improving. And hey, I can go to school now. Hey, I can read a little bit longer now. I don't burst into a smelly sweat when I get stressed out anymore. So we should be seeing functional improvements as our tolerance to our working out is improving. And then we repeat the test. But like I said, we don't always get to it weekly. We don't follow our own advice all the time. But the more chronically deconditioned or the closer to POTS they are, you're not going to find weekly changes anyway. So 2 to 4 weeks seems to be adequate. So if the patient is deconditioned, so if the patient is somebody like me, where it took unfortunately 10 years to have my POTS diagnosed, and so I couldn't exercise for that long, we are going to get a little bit of different instructions than my triathletes that come in and are noticing that when my heart rate gets into the 170s now I get symptoms, right? Those are going to be two different animals and you have to treat them differently. So a blanket protocol isn't going to work in that case. So they get specialized instructions. They might not be able to tolerate 20 minutes. So they might get 2 sets of 10 minutes, or they might get 5 minutes at a time. They would be the people who have to start in the horizontal plane. So laying down, riding on that Chuck Norris total gym, right? So there's lots of options to get in exercise, even though we have to keep the heart rate low. The reason horizontal plane is so important is because you automatically have a lower heart rate. So most of these patients have orthostatic intolerance. They have an elevation in their heart rate in standing. So they might be standing on the treadmill before the test starts and the heart rate's 105. Well, if your target heart rate's 100, you can't walk for your exercise, right? Because you can't even stand at less than 100. So you sit them down, their heart rate drops. Now I have a buffer zone where I can actually work out. If they have mild deficits, we start right away with the 20 minutes and we just build as we reach the 80% of our age expected heart rate max. They get a 5 beat per minute window. What we found early on was if I asked them to exercise at 100, they would come in a state of panic that they couldn't keep their heart rate at 100, so they're not getting better. But of course you can't. You're not supposed to have a flat line when you exercise. There's supposed to be some ebb and flow. So we started giving them more of a window just to sort of ease some of that panic. Once you can complete 20 minutes of exercise at your prescribed heart rate without your symptoms increasing, that's when we go up by 10 beats per minute. So it's a very standardized way to approach everybody differently. You just have to meet 20 minutes symptom free and then you progress. So when you educate your patient, whether you're the one actually doing the treatment or you're in the reinforcement role, explanation of what's happening is very important. If they go home and they doctor Google, they are going to send you emails like I received from a patient's mother that said, I read the life expectancy of POTS is 5 years. No, I don't know what you read, but that is not true. So I've actually started asking them just to trust me and not Google, because it's a little bit of a horror show out there on the internet. So the more that we can explain to people, the better they're going to feel calm about their diagnosis, the more likely they are to adhere to the treatment. It's very important that they understand that this is exercise for their nervous system and their brain, especially if you have an active, healthy person and you're asking them to exercise at 100 beats per minute. The first thing you're going to get back from them is, that's not exercise. Well, no, not in the way that you're used to it, right? It's not exercise for your muscles, it's exercise for your nervous system. If they don't have a wearable device, which isn't accessible to everybody, you can use a ratings of perceived exertion scale. The problem with that piece is that we've had a really hard time with compliance with that. And we've had a really hard time because these people don't have an accurate depiction of what level of effort is sometimes because of their symptoms. So we are starting to recommend that people just purchase a Polar heart rate monitor. I don't get anything from Polar. They just have the best research. They're about 94% as effective as a 5-lead EKG. If you're going to purchase a device, we're not going to purchase a wearable that may or may not work because you don't have good peripheral blood flow. So if you're going to spend money, I want you to spend money on something that's going to help us the most. So our home exercise program, all of our parameters are established using our test data. So we try to keep it as objective as humanly possible. And that's really helping us track what's happening with these patients as we develop our protocols. We want you to do 20 minutes a day. If you're an endurance athlete, that might look different. It might be that your prescription is 40 minutes a day because we have to combat some of these effects of deconditioning. But the average person, the goal is 20 minutes a day. They might have to start with less. We want to make your brain happy. We don't want you to feel profound fatigue when you're finished. They're not going to get any adherence if I make you feel worse, right? I want you to start to feel refreshed and happy and starting to feel like you're self-motivated to do your exercise versus being forced to. That means I'm doing my job correctly. Okay. And then we incorporate lower extremity strengthening and core strength because we want to start to facilitate that muscular pump. So you have what's called your autonomic tone, and it becomes very sluggish in dysautonomia. So if we strengthen our leg muscles and our core, we strengthen that pump and we get to move that blood flow around more effectively. And then clinic goals. So if you are asking, well, how am I supposed to write this in my goals? We don't even know how real this is, right? So there's ways to write functional and objective goals. So I might write something like patient will tolerate cardiovascular exercise for a minimum of 20 minutes with a heart rate 80% of their age expected max without symptom provocation, right? And then you could put your number of weeks. So if it's a more chronically deconditioned athlete, I might have to write 16 to 20 weeks for that goal. That doesn't mean we're going to be best friends and hanging out once a week for 16 to 20 weeks, just to clarify. This is things you can do at home all by yourself. Initiating a strengthening program. So as soon as that patient can start to tolerate a little bit of low-level cardio, I want to start to add in that horizontal plane exercise. Remember that this is not just dysautonomia the way you see it in the literature. But this is dysautonomia in the world of mild traumatic brain injury. So you have to always defer to those concussion return to sport protocols first. If the patient isn't cleared to be in a strengthening stage because of their brain injury, you can't add in strengthening just because they also have POTS, right? So you want to really make sure you're deferring to the brain injury and then you're treating them in an integrated way. For our high level athletes, our athletic trainers on the Wasatch Back are doing an amazing job. And so often they'll actually be the ones that are doing the day to day monitoring. And then I just get a message and I can help them progress. So that's really exciting when the athletes are able to go through the protocol that way. So we're just going to go briefly over a case study. This is over a patient whose primary driver for their mild traumatic brain injury was dysautonomia. And we know that because we basically didn't treat anything else, right? But also most of their symptoms were associated with dysautonomia. So he was a 40-year-old male, about 40 days post-injury, and he had had a slip and fall. So falls are the majority of mechanisms of injury, even though sports gets all of the information and all of the highlights, right? The interesting thing about this patient is he had COVID twice, and COVID has really, post-COVID or long haulers have been really throwing a wrench in all of our protocols. So that was just an interesting fact about him. All of the myriad of symptoms, right? And as I started to say, these patients will sort of scream at you getting off the elevator, right? So you know exactly what you're working with once you learn how to ask the right questions. Hot, cold fluctuations. What was really interesting about some of these more type A driven people is that they love to explain away their symptoms. So we're sitting there having our evaluation, he's talking to me, and all of a sudden he's taking off layers. He's getting stressed out talking about his symptoms, and he's coming down, he's all the way down to his t-shirt, right? So what's going on there? He says, I don't know. I just get these hot flashes sometimes. It is the weirdest thing. And I said, well, does it happen with exercise? Oh, no, no, no. I get overheated sometimes with exercise, but that's it. And then I said to him, well, what happens after exercise? Oh, well, then my temperature is all over the place for a couple of hours, right? So it's really interesting how they'll present to you. The sleep issue, I hear this a lot, but he would have a lot of nightmares at night. And there's a lot of patients with mild traumatic brain injury that will describe nightmares. So we just have a nice overall presentation of someone who can't function. This is what the first Buffalo concussion treadmill test report looked like. When one of mine is on the screen, it tends to look a little bit insane. So I like to write everything I possibly can down that's happening. But you can see how we have these wide varieties of heart rates. So in each stage, the workload isn't changing. So our heart rate should only be having a little wave to it. And so for these people, you'll see anywhere between a 5 and 10 beat per minute change within one stage. You can see the RPE increasing. And then the reason that I stopped this test was we were having a lot of autonomic symptoms. So a lot of the swelling, the hot flashes, we were having some sweating happening, things like that. His prescription, because of the way that his test result went, was 105 to 110 beats per minute. And this is what the wave of his heart rate monitor looked like. So you can see on that first third of the test, the heart rate is up and down and up and down and up and down. Then we hit that critical tipping point over 120 where we start to normalize a little bit. We have a smaller wave, still some big blips. And then we have that rapid failure point at the top. But that's not really what a heart rate graph should look like. And I'll show you at the end of this case what it should look like. And so what I did was I took his max heart rate where the autonomic symptoms started. So it ended up being about 120 to 130 beats per minute. That's why his prescription was so low, even though he was able to get up to 150 beats per minute. So again, I took his max heart rate as where the autonomic symptoms started, and I took 80% of that max heart rate. So he left for 2 weeks and came back and told me that already we were having peaks and valleys with our exercise, but we weren't having big jumps in our heart rate when we're walking. He's able to do more in that low cardiovascular range. He was able to see his heart rate stabilizing more, and already symptoms are improving. Like I said, we should be having functional gains as our tolerance to exercise improves. We're not having cold sweats anymore since I stopped doing the things that were naughty, right? I stopped doing my high intensity cardio and magically my sweats went away. He's able to increase his exercise while staying in that same range. So we went up by a mile, even though our heart rate didn't allow us to go up higher. So we stayed in that 105, but we could do more output. Then we had our second follow-up. Our third visit was our final visit. So that was it. 28 days later, he's 80 days post-injury. We're normal. We had that huge list of symptoms in the beginning, lack of function, and now no real problems. Sometimes when he would get up into a higher level exercise, he would start to feel symptoms, but he was much better about self-monitoring, which was probably the number one thing I did for him, was teaching him how to listen to his own body. Back working at 100%, doesn't feel restricted, even went for an unapproved bike ride down in St. George, which is our mountain, our southern area. And then he apologized to me because he knew he wasn't cleared for that, but it went really well. And then this is what our second test looked like. So you can see how there's still a lot of writing because I am who I am as a person, but it's much cleaner than the first one, right? There's not as much to report because he was normal. He reached his 163 beats per minute, 20 out of 20 RPE, max effort, couldn't have gone better, nothing during the recovery zone. And this is what a heart rate should look like. So we still have some blips in that lower range. We want to see a nice wave because we want to see parasympathetic involvement below 120 beats per minute. I would love to see a couple of those little blips a little tighter. Then we have in the middle third, a beautiful wave. So between that 5 and 10 minute mark, there's that really nice curvature there. That's perfect. And then we hit that second anaerobic threshold above 140, and we have almost a straight line up. So what should happen is we hit that second anaerobic threshold, the workload is still increasing, so we have a rapid increase in our heart rate until we max out. So that's what it's supposed to look like. Not 100%, but a lot better. And then here you can see them side by side. So this is just 3 total visits, a myriad of symptoms that have improved, and then we were able to see this physiological change. We were able to prove that we could improve his dysautonomia. And then these are the questionnaires that we cover in our office. So we had clinically and statistically significant changes across the board in all of our questionnaires. So we were able to have a really great outcome with this patient. There are some structured protocols that are available specifically for POTS. What's great about this is maybe you're a OT or a speech language pathologist or a psychologist, and you're in an area that doesn't have a lot of access to healthcare. You're able to use some of these more standardized blanket protocols that go based off of the patient's age and their age expected heart rate max. And you could at least do something to help facilitate these patients. The research is on the Levine and CHOP protocols primarily. The problem is they allow a lot more interval training early on, so they do allow a higher heart rate early on, and so patients tend to not tolerate it as much because of the elevated symptoms. So we're looking for some faster and easier access points to treatment for these patients, a little more standardized approach. But these are out there, and you can Google them, tons of research about them.
Thank you, Dr. Zayaks. So in kind of conclusion to everything that we've been talking about, we just want to summarize some of what we call our clinical pearls. And the first one being that dysautonomia, as we know, can often be misdiagnosed. As we said, it can take 4 to 5 years, 7 to 10 physicians for somebody to be properly diagnosed. So improving awareness across all disciplines and anyone who works with somebody who's had a mild TBI, we hope that that can promote more efficient referrals so these patients can be diagnosed and managed properly sooner. As Dr. Zayak said, there are many standardized tests, but as we can see with some of these patient symptoms, we do have to modify to manage to get through these tests and measures effectively. And while home heart rate monitors can be wonderful and very useful, we don't need them, they're not necessary. So you can really help these patients follow these protocols with really no equipment in their home. It's just a lot of education. Teaching your patients in a tangible way what exactly it means to have maximal exertion or submaximal exertion, what it means to monitor their symptoms, and to keep in mind what their specific goals are and why they play an important role in the recovery process. And to just remind everyone that no matter what your discipline is, I know Dr. Zayaks and I are both trained physical therapists, but anyone who works with somebody who has dysautonomia after a concussion can play a role in supporting them. This can be a very challenging diagnosis to manage. It's a very emotional process to go through. So just supporting them through this process, helping to provide them education. And if you don't feel comfortable giving the direct education, pointing them to the proper resources or other professionals who can help provide that education, and just encouraging them to stick with it. It can be, like I said, a very long, frustrating process. So encouraging them to understand that this is all rooted in research, and it is important to follow these protocols to see the results that we're looking for. Just also wanted to mention that Dr. Zayeks and I are currently in the process of producing a study where we looked at, it was a retrospective quality analysis, and there were about 50 patients in between, I think it was August 2019 and early 2020, who underwent these Buffalo concussion treadmill tests with suspected dysautonomia after concussion. And what was interesting is that so much of the research, particularly coming out of Dr. Letty's group in Buffalo, really focuses on that young male athlete population. And our population actually was primarily female, a little bit older, so average age was 22 and a half, and they were further post-injury. And so of this group, when they were given the Buffalo concussion treadmill test, only 3 were able to actually complete the protocol as established by Dr. Letty. And the other 47 participants were unable to reach that protocol because of these symptoms listed here. Either they weren't able to stabilize heart rate, they had exacerbation of their concussion symptoms, they had autonomic nervous system symptoms, etc. And so we had, they were unable to achieve that maximum target. And so what we're trying to point out is that some of these protocols, such as the Buffalo concussion treadmill test, although they can be great in recovering from a concussion or a mild TBI, they do need to be modified if somebody falls into that dysautonomia bucket that we've been talking about. So we want to thank all of you for joining us today. We hope that you learned at least a couple things, and we would love to field any questions that you have.
Wonderful. Thank you so much. We have a few questions that have come in, and just a reminder, if you haven't typed it in, please do so in the chat. So the first question that came in from Deborah: how do you help patients that are afraid to exercise due to feeling so poorly for so long?
I feel I can talk to this because I've been that person, and also because I see that person all day long. And so you have to treat them with kindness. I always say that these are people, right? And they're the ones who are more deconditioned, the ones who have been chronically ill are going to have a harder time getting started. And some of them just need some tough love. So when I was diagnosed, I was a little bit upset because my prescription was 2 sets of 5 minutes a day on a recumbent bike. And I said, well, that's not exercise and I'm not going to do that, which is exactly what annoys me that my patients will say to me, right? But we're all human beings. And so my colleague Christina had to manage me with a little bit of a heavy hand in the beginning and tell me to get over myself. And what you'll find is that if you get the prescription right, if you set the right parameters and you encourage them the right way, it will take a solid week or so for them to get over that fear of all the symptoms they've had in the past after exercise, and also start to be able to enjoy it again. So it's a pretty quick turnaround, where that first few days, that first week is a struggle to get them on the apparatus that you've prescribed. And then they start to notice, I don't have to force myself. So patients will say that, and I've said that myself. You know what I found? I don't love the prescription that you gave me, but I don't have to force myself to do it. And that's the critical turning point, where they start to develop a better relationship psychologically with exercise. That fear component goes away, and then it's off to the races.
I would also add to that, one of the other strategies you can implement is to come at it from an interdisciplinary approach. So if you have somebody who, you've done all the things that Dr. Zayeks talked about, and they're still really struggling with that behavioral, emotional, cognitive component, reaching out to your fellow colleagues, maybe neuropsychology, to help see if there are different strategies that you can reinforce that the patient might be working on in one of their other sessions with a different discipline. So it's another.
Thank you. Thank you so much. So the next question that came in was from Esther, and Esther works primarily with IPV survivors. How can clinicians discern the difference between symptoms of dysautonomia and PTSD, particularly if a patient presents to ED and BI is not immediately diagnosed or suspected?
I can take that one if you want me
I
to.
feel that one. I
Yeah.
feel like I can see your brain going.
I could talk about this all day. Okay, so those are great questions. Here's the problem. Unless they had pre-existing dysautonomia, which is likely because unfortunately people who are victims of IPV tend to be repeat victims of IPV, right? And there's a lot of statistics about how many people are walking around with undiagnosed brain injuries purely because of that situation. So maybe then you could identify in the ED. But what we're finding is these symptoms actually don't develop for a period of time. So there's an article recently that was published by Miranda et al., and it was related to dysautonomia and concussion. I believe it was from about 2017 or so, if you wanted to look it up. And what they talked about was actually doing serial examinations for dysautonomia. And this happened to me twice in the clinic last week. So I had a patient I hadn't seen in 3 weeks. They were telling me that exercise was the only thing that made them feel better. And then all of a sudden they come in with a myriad of new symptoms that weren't there before. They had passed their Buffalo concussion treadmill test early on. They wildly failed and ended up getting diagnosed with POTS just a month and a half later. So in the ED, it's going to be a challenge, and it's a challenge just to get the TBI diagnosed in ED sometimes, depending on the other orthopedic injuries. So more so you could just tuck a pamphlet of information into their folder that they get with their discharge paperwork, or you can educate some of the people that are working in your system that are touching base with these patients later on and looking for these types of symptoms or developing a questionnaire or things like that. So there's a lot you can do, but just very early on, it's going to be a challenge and it may not be that accessible to you.
Okay, the next question, I'm not sure, it might be related to that from Patrick. How do you discern between the patients with post-COVID POTS and POTS from a mild TBI when they have had both?
Do you want me? I could take that one.
Go ahead. Go ahead. Yeah.
That's a great question. And the answer is who knows? Because your autonomic nervous system is your autonomic nervous system. So whether you were predisposed because you have celiac disease or another autoimmune disease, and then you have your triggering event, which gives you POTS, we don't treat those people differently. We just sort of respect their autoimmune conditions. The similar thing will go for the post-COVID POTS. So maybe they had COVID 6 months ago and they were having a little bit of exercise intolerance. They weren't really realizing there was a problem. Then they have their concussion and now all their symptoms are worse. Whether it's just a historical fact in their history, whether they're coming in and they haven't had a concussion at all and they've only had COVID and they have POTS, it's all the same treatment. And there's no way to go back in time and to study their nervous system before they enter your office. So the most important thing to know is that somebody who has COVID in their history seems to be more complicated. They seem to get better more slowly, but we don't have any research because it's so new. We've all only been dealing with this for a year. We've only been seeing these long haulers start to trickle into the clinic in the last few months. And so I don't know how much different they're going to be in the long run than people who've only had a mild traumatic brain injury, which is interesting to say, only a mild traumatic brain injury, right? But ultimately, you're going to treat them the same. You're going to follow the same parameters. And in your documentation, you're going to note that they have this complicating factor because people who have more complicating factors tend to have a little bit more coverage and things like that. So it's good to know because if they do get better more slowly, you can argue for more visits and things of that nature.
Thank you. We have a question from Laureen. Are signs of POTS commonly seen in the adolescent and pediatric population?
So I can say that there is research that's come out in the last couple of years that is showing there is an increasing prevalence in finding POTS within adolescents. I don't know if I could speak specifically to pediatrics. Dr. X, I don't know if you have more information on that, but yes, it can be quite common in adolescents, particularly because the rate of mild TBI is pretty high in these young athletes. In addition, they tend to have habits that don't promote very good autonomic nervous system health, if you will. So not such great sleep habits or other kind of, things that may not help promote that recovery properly.
Yeah, also for POTS, so heart rate is the primary diagnosing factor. So in adolescents, they have to have that 40 beat per minute increase. And so in the pediatric population, tachycardia is actually quite common. So the diagnostic criteria starts at about 12 years of age. I'm sure that you could diagnose someone younger. We have a patient right now who's 9.5, but we're kind of questioning whether or not it's a true POTS diagnosis just because of those complicating factors, although he has all the symptoms and is responding well to treatment. But we're just cautious about the label there because of the long-term implications. Adolescence is the majority of the research. About 50 to 60% of patients will start to have an onset of symptoms in their adolescence. What's really interesting, and they talked about this at the Dysautonomia International Conference, is that the research says that people can grow out of having POTS, but then when you look at the actual data from that big nationwide clinic that people know, they're saying that people grow out of it, but then at their own data, it's saying that only 30% of people grow out of it. So you might hear in the world that people who are adolescents, particularly females, there's no real point in treating their POTS because they're going to grow out of it. But the fact of the matter is only about 30% will. And why are we going to wait 4 years for you to become not an adolescent anymore when the treatment is so accessible and fairly easy to manage? So I don't want to do a wait and see for half a decade to see if someone becomes symptom free on their own. I want to treat it right away. And then we'll never know the answer to whether or not they would have grown out of it, but I don't care because they're back to functioning.
Thank you. Next question is from Nicole. If you suspect a patient with dysautonomia, which specific MD specialist would you recommend them to?
So that's a great question, and it depends. Technically, we should have a cardiologist involved. We should have a neurologist involved. We should technically have access to an endocrinologist because of the hormone changes and the pituitary gland changes and things like that. And a GI specialist because 2/3 of them are going to have issues. But not everybody's going to have access to an incredible clinic of that nature. And the ones that do exist tend to have anywhere between 6 to 12-month wait periods, right? So we want to definitely have a cardiologist because these people do have tachycardia. You want to add a lot of salt to their diet. So you want to make sure that you're not having recommendations that are contraindicated because you're missing PVCs or you're missing AFib or things like that. So if we're going to talk not for dysautonomia, because most of those people, it will depend on your care management model, but POTS and OH and things of that nature, you want to at least be able to refer to a cardiologist. A neurologist being involved as the global person that's running your program is a great idea anyway, and then educating them about POTS so that they can help support your mission. When you refer on to a GI specialist, they've got some really great tests that they'll do where people actually swallow a pill with a camera and they'll be able to measure the motility in different sections. And you actually have a bunch of different valves and they can move more sluggishly and people can have issues with how food moves through their system, which is why they become so sick. So people with a lot of GI complaints, you want to be able to send on to a GI specialist. And then of course your endocrinologist, patients will complain a lot about changes in their hormones, such as their acne, or I've had patients say, I haven't had a normal menstrual cycle in 2 years since my head injury. And what's fascinating is it goes back to normal a lot of the time after you treat their dysautonomia. So the problem with all of those different specialties is that you need a quarterback who's going to be actively involved and wants to be a part of your team. These patients are extremely challenging. They are extremely time consuming. Because of the amount of time the physician might have to spend with them, they often will actually lose money for the hospital system. But you know, that's okay because we really want to be helping these people in the community, but that is something that the hospital network might think about. So you want someone who really feels this population and is excited to be a part of it because managing their care is time consuming, but it's life changing. And so that's the biggest piece. Find the person who's going to be your quarterback.
Wow, thank you. Okay, next question is from Lisa. What kind of exercises do you like for patients who can only tolerate a supine that can increase HR more than basic TE? I hope I said that word correctly. SUPINE.
Sorry, I had to read it. My
Yeah, I
auditory
didn't see that question
processing.
either. Okay.
It's in the Q&A.
Now I found it.
Do you want me to take that one?
Sure, yeah.
Okay. So when they're Laying down flat, the general cardio could come from just a biking, so they pedal their feet in the air, but a globally deconditioned person isn't going to tolerate that actually. So because it's a lot of core involvement. So maybe we'll have them slide their feet alternately, or even put their feet on paper plates on a wood floor, because that decreases the friction and will make it even easier for them. We might have them put their legs up on the wall, because that will also artificially decrease their heart rate because their legs are up while they're laying down flat. For exercise equipment, we love the Total Gym because I like it. Basically, I like to break a patient anytime they give me any sass. So they're like, well, I can't do your exercise because you won't let me do anything. You didn't do anything for a year anyway. So like, I'm not like holding you back. I'm actually encouraging you to do something, right? So I'll put them on the Total Gym and I'll add some weight to it, and then they'll start to sweat, but their heart rate is low. And so then they're like, well, I'm getting a workout. Well, I thought you said you couldn't get a workout, right? So you try to just kind of to push them pretty hard to show them that there's so much they can do. Bridging series, leg lifts. You can do side lying abduction, glute med exercises until they're blue in the face and push them to failure, and their heart rate will never go up. They tend to not do very well with anything where they have to hold their breath. So planks tend to be quite challenging just because it increases the ICP, the intracranial pressure, and their heart rate will also go up. So doing things that are slow and with reps. And you have to explain to people the basic science of, if you move slower, your heart rate will go down, right? So they'll say, well, I can't do those bridges because my heart rate went above 95. Well, okay, do them slower. Pause for a second in between each rep. And then all of a sudden, their heart rate comes back down again. Leg press machines, hamstring curl machines, there you can get so creative with what you can do in that low heart rate that it's almost overwhelming and hard to get started. So sometimes I'll take a session and I'll actually bring the patient with their heart rate monitor on through the gym and show them all of the things that they do have access to. And that can be a really great use of time because it can turn a non-compliant patient into a compliant patient. Whether it's just the shame of them not realizing how much they can do or the opening up of the access to them. But either way, it tends to work pretty well.
And we have a question from Kimberly. If someone is 6 to 7 years post concussion, could they still be experiencing dysautonomia?
So, Dr. Gar, I assume that you mean, since you wrote could they still be experiencing? Yes, absolutely. If somebody has symptoms of dysautonomia that have begun and have not been treated properly, they can absolutely last for years post-injury. It's less likely if somebody has a concussion that all of a sudden 6 to 7 years later, they then kind of randomly develop symptoms. But yes, they can absolutely, if not treated properly, not only be there 6 to 7 years later, but potentially continue to grow worse over time.
Yeah, that's a great point because deconditioning is going to happen much more quickly for these patients. So if Dr. Tucker were to be in bed because she had the flu for a week, her nervous system is going to respond much more positively to that prolonged rest than me, who has a history of POTS. So what's really important and what's really exciting as we finish up here is that this is a treatable condition no matter how far out you are. It's just that the longer out you are from diagnosis, typically the more deconditioned the patients are. We do see patients who are 6, 7 years out who have never stopped exercising because they've never put 2 and 2 together. They always feel better during exercise and worse after. That's a much easier person to treat than the natural progression, which is someone like me. Every time I exercise, I feel like garbage, so I'm just not going to exercise. Well, then the problem compounds on itself. So at 6 to 7 years out, you absolutely can have those symptoms. You've probably been diagnosed with a psychological problem by a physician at some point because you have this wide myriad of symptoms that don't make a whole lot of sense if you don't know what you're looking for. Or you have psychological issues and mental health challenges because you've felt really terrible for 6 to 7 years and can't exercise, right? But what's really great is exercise is the prescription. It's daily. People who long-term have these issues, we don't know in the world of head injuries if it's going to follow the same trajectory as people who have dysautonomia for the other reasons, right? So what I'm recommending to patients for right now is that, hey, we don't know what your long-term outcome is. However, even if you do have this sort of relapsing, remitting episodes of POTS or dysautonomia, this treatment is always going to be the same. It's daily exercise. You don't want to miss more than 7 days in a row of cardio. So if you break your ankle and you're in a boot, I need you to make sure that you get on an arm bike at least every other day and you maintain your cardio. So you just have to think about life a little bit differently than the average person, but it's not that challenging. Get in the pool and swim to keep up your cardio, ride a bike, things like that. The research shows they start to slide backwards after about 3 days of not doing their cardio. And after 7 days of not doing your cardio, you may have to go back an entire stage or even start over. So maintaining cardiovascular exercise is the most important piece long term for managing POTS and dysautonomia.
Well, I want to say right now, thank you so much to Dr. Lauren Zieks and to Dr. Jenna Tucker for this amazing information and answering all these great questions that came in from the audience. I want to remind everyone that's in attendance to please complete the evaluation, especially if you're going for CEUs. Kristen has put all of the links in the chat box. So, and right now you have some time to go visit our exhibitors and try to win those prizes. And also to take a look at the college posters, which the students put so much hard work into. They really are great. Please take the time to visit and take a look at those also. The next group of workshops will begin at 11:55. So you have time to visit the exhibitors, see the posters, also grab something to eat, and then come back for the next round. Thank you everyone for attending this workshop. And again, thank you, doctors. Have a great day.
Thank you.